Well, thank you very much, Mark, and thank you for the invitation. It's really a pleasure. I actually was in Swim at the OMC clinic on 5th doing clinic yesterday. It was a beautiful day out there, and it's really something I've enjoyed coming out to the peninsula about every 4 to 6 weeks to see patients who have a struggle getting into Seattle. So I chose this title for a couple different reasons. A little bit of a play on the movie 2021: A Space Odyssey, and we'll get into that in a second. Want to wish everybody a happy St. Patrick's Day. Can't not do that. It's a picture from my hometown of Chicago where we very smartly dye the river green there. I had to get that in because of a little bit of my Irish heritage. So today we're going to talk about spine care, and kind of was trying to think about how I could make this relevant to everyone. And I came up with this concept, and for some people who are too young in the room, they won't remember the movie 2001: A Space Odyssey, but it's a big deal when we were kids, this movie about outer space. And I put these two pictures for those of you who've seen it. One is the lead character who is an astronaut, and the other is another part of the movie where there's an ape gaining awareness. And I kind of feel like this is my medical life, which is all the great technology that we have on the left, but also that I'm still just operating on the right, which is still probably will be seen in many years as pretty barbaric. But I thought this was a great juxtaposition just to start off the talk. So the other motivation for this is, obviously, I think for all of us, the last 2.5 years really have been something strange and different. And it was certainly true for the surgeons. Really, we had to look at disease very differently, and we had to triage what we thought was important because of the pandemic and because of lack of resources, staff members who'd go out. So with limited resources, we really had to make some decisions about what was going to be treated and what wasn't going to be treated. We had many less in-person visits, which helped some people to be seen remotely. But when you talk about the neurologic exam, it left a little bit to be desired in terms of how you could do a neurologic exam, although we've gotten better at over the internet and with Zoom meetings. Lastly, we got to see kind of the evolution of diseases, that particularly spinal diseases, that we wouldn't normally be allowed to see because we couldn't take care of these patients. And really, you had to have an extraordinary problem, surgical problem, to be treated 15 months ago. Really, the triage was stunning how many things got delayed. So the goals today, I'm going to keep pretty basic. We're going to kind of go back to the basics because I think all of us have a little bit of rust with different things. Just talking about at least my perspective on basic degenerative spine disease. I can certainly come back at any time and talk about the technology side of spine, the epidemiology part of spine, where I think we're going with the Medicare population. But I thought it might be useful, again, just to get back to basics. And that's what we're going to be about today. So I'm going to break this into kind of different regions of the body. We're going to talk about the most common things. And again, I want to make sure that I'm just trying to share perspective. I will make this as peer review driven as I possibly can be. So acute lumbar back pain, all of us see it. We know how common it is. By the time we reach 80 years of age, 85% of us will have talked to our doctor about treatment. It's usually self-limited. I think what's key here is this third point, which is I love my radiologists. They're incredibly helpful, but modern radiology does not really provide good anatomic pathology that we can somehow relate to both the diagnosis and prognosis of back pain. And we have all these words in our radiology reports that I'm sure you read, that none of them that sound good. And more often than not, if you're over the age of 60, you're going to have the word severe in your lumbar MRI scan. And I would say that a good part of my clinical life is when patients come in and say, Doc, I know what's wrong with me. It says severe here on my MRI report. And severe never sounds good. There's no severe well-being, severe health, or severe health and wellness. So it's really interesting how we have to kind of deal with that cultural nomenclature. And again, when I say the problem with radiology, it's not the problem with radiologists, it's just the nature of the technology we have. And I I present this paper from way back in 1994. I think it's really interesting that it was almost 100 volunteers who never had had back pain in their life, never anything that they really took medicine for, with an average age of 42 years old, but people as old as 80 years old and young as 20 in this study, and only 36%, so only a third of those patients with no symptoms had normal MRI scans. So I try to reinforce this a lot to my patients to say, an MRI scan can give us very useful information as long as there's correlates to it clinically and historically, but we have to put an MRI in its place. It isn't the end all be all. It very often can confuse us or not give us the correct answer. So most of the time when we talk about acute lumbar back pain, we talk about judicious use of medications. I think therapies can be very helpful. I think there are certainly times when spine rehabilitation practitioners, this would include sports medicine, physiatry, occupational health doctors, can be helpful, as can pain interventional doctors, again, whether they're anesthesiologists or some other training that are involved in helping us with those procedures. But I think, again, provider reassurance is very important here. And again, we're talking about, I threw my back out, acute episodes of lumbar pain where that pain is really just staying in the low back. Okay. I think it's important that we recognize that this is such a common problem, but there's times when we have to really scrutinize more carefully. And I really think these are the 6 biggies that I think of where it probably has to really be looked at as maybe it's not just that run-of-the-mill, I threw my back out. A cancer diagnosis, even if remote cancer diagnosis where bone mets are common, prostate and breast would be probably the most common that you would all see. Trauma, obviously. A person's age, their gender, their bone health. Poor nutritional status, and this can be the cachectic patient, this can be the more morbidly obese patient. If they've had previous surgery in the low back, especially if they've had hardware put in the back for a fusion. And again, an IV drug user who has unexplained fever with new back pain. Again, this can be a tough one, but the difference between catching an epidural abscess in the low back in someone in the first few days and an epidural abscess 3 weeks later can be dramatically different in the morbidity and even mortality associated with that. I want to talk about this a bit, this symptom of incontinence. Classically, a patient will call and say, I this pain and I couldn't make it to the bathroom, or I had an issue. And I think this is really important clinically to think about this. And I know this is obvious to many of you, but I'm going to state it anyway. It's very hard to have cauda equina and you can walk simultaneously. There are supports that it can happen, but it would take an extraordinary structural problem to say, I'm losing control of my urine from compression of the fecal sac, but I can still walk. The chronic use of narcotics, even at low dosages, can really lower the threshold for incontinence with a new episode of low back pain. This is the person who takes low-level narcotics, they get an episode of low back pain, and those chronic narcotics have made the bladder kind of lazy and made the sphincters kind of lazy. And so, again, when these symptoms get brought up of the problem with incontinence, be thoughtful of that, okay? I'm just putting this ambulation and cauda equina can rarely coexist. And always be thinking about the incontinence issue should be coming with perineal numbness and saddle anesthesia. Again, when incontinence, again, whether fecal or urinary is coming by itself, my worry about the acute low back pain really being fecal sac or nerve compression is actually quite low. Now we're going to talk, if we can, about things that I think I hope are clinically more helpful to you. So now we're going to talk about structural spine disease with neural dysfunction, what we would call compression. And I'd like to go through what I would call the 6 biggies. Again, we're not going to get into a little bit more nuanced stuff. We're not going to talk about spinal tumors, but really probably the meat and potatoes, 95% of what you would see and probably what you would refer on to us. And at the end of the talk, if we want to talk about more nuanced things, we can. I'm going to move through this fairly again, expeditiously so we can have time at the end for any questions. So this is the easy one, herniated lumbar disc disease, the acute onset of radiating pain. And why does this occur? This is a cross-section cartoon of the low back. We're going to call it the L4-5 disc in this picture. Here's a sagittal view, here's an axial view. And this strong outer rubber band, which holds the softer part of the disc in, called the annulus, gets weak over time. It can bulge, it can tear. Whatever it does, it causes compression of the nerve exiting the spine. If I have an L4-5 disc space and I have a herniation there, it can cause irritation of the nerve that's right there in the lateral recess, called the nerve that's passing through, or it can pinch the nerve that's about to leave the spine, called the foraminal nerve. So in this case, a nerve disc herniation can cause L5 compression here, or it could cause L4 compression here. That's advised both the MRI scan and what we see on the physical exam. So here would be a classic example, sagittal MRI scan. Here's an axial, and here is a broad-based disc herniation, and the arrow is pointing out here where the nerve is being compressed. So it's kind of a nice midline disc herniation, but the mass of this is really giving a left-sided symptom. Okay, and could this person have bilateral symptoms? Yes, they could. But in this case, it was a case of a left-sided S1 radiculopathy. Again, L5-S1 disc. When it's getting the nerve that's traversing through, it's the lower number S1. If it was a foraminal disc, it would be L5. Classic clinical presentation. Subacute low back pain that all of a sudden changes. That subacute low back pain turns into buttock pain or anterior thigh pain based on location. And as someone who has had a disc herniation, had surgery for it, it really did follow this path clinically for myself, which was about 3.5, 4 weeks of really odd low back pain, which all of a sudden disappeared over about 24 hours, likely as that disc was bulging and finally ruptured, and then actual compression of the nerve. There are varying degrees of pain below the knee and into the foot. So I really focus on the butt, sciatica, and the thigh for the upper nerve roots 1 through 3. Walking may improve or increase pain, but the important thing to understand with disc herniations, it's pretty random. When we talk about lumbar stenosis a little bit later in the talk, we're going to talk about why walking and standing is so different. But in this case, it's hard to really get the patient to say, sometimes I walk, sometimes I sit, but it's really random and this is very painful in my buttock. Pain usually awakens patients from sleep, especially in the first 2 weeks. Another very important point, when a person's sitting down, if you gently extend their knee, almost always causes an increase in pain, which is relieved when you let the knee bend again. Motor exam, absolutely one of the keys to the diagnosis, especially when an MRI scan shows multiple problems at multiple levels. If we're trying to really get a really good idea of what this is or isn't, actually the exam and understanding your dermatomes and myotomes becomes important. But I really want to stress motor exam above deep tendon reflex exam or sensory exam. An EMG, which we sometimes do, is not really of any utility until at least 4 weeks after the onset of symptoms. And it is not prognostic. We will use EMG sometimes where we have a question of, is this peripheral neuropathy, or is it multiple nerve roots, or is it a plexus problem and it's not really a disc herniation? But really an EMG does not add much more than we can see on the MRI and much more than we can see in our physical exam. Obviously, I don't think I'm telling anyone new. We've always got to be careful we aren't seeing new hip disease, SI joint dysfunction, a pulled muscle, especially the hamstring. And important, when your patient is asking you about the MRI scan, which says there's a very large or large disc herniation, the size of the disc is usually not relevant to how much pain is associated with the herniated disc syndrome. Okay? The majority of patients will have this severe pain go away in 2 weeks. Obviously, we use different types of medicines to do this. I think for this kind of pain, unlike acute low back pain without a pinched nerve, Gabapentin and Lyrica should be a consideration. Again, PT, gentle massage, mobilization after the pain has gone down. But to be clear, whether it's PT or chiropractic or gentle massage or even epidural steroid injections, when you compare those modalities versus simply doing nothing, there's been no modality that's been shown to change the clinical profile at 6 weeks. It doesn't mean that these things like PT and massage and the chiropractor can't provide wellness and benefit to the patient. It's just to be clear that there is a natural history where many, many people get better in time. Obviously, an MRI or CT myelogram is what we use. It has much more diagnostic value than X-ray or CT scan. I don't think it has to be done the day of sciatica sets in, but that's what we use as our primary diagnostic tool. About 2/3 of patients at 6 weeks will have achieved clinical stability of pain, meaning whatever group of therapies that have been performed, they'll say, really, from a quality of life perspective, I don't have that terrible pain I had at first, okay? It's not until about 6 or 8 weeks that as surgeons, we really want to have a consideration of even discussing surgery. But if we are having those considerations, we know that surgery, which is an outpatient low-risk procedure, is going to leave a high number of patients very satisfied. But notice that it's 85%. It's not 95%. It's not 99%. So a lot of patients come and see me, and they're very nervous about nerve injury, right? And the general rule of thumb is surgeons should not be as worried about permanent nerve injury. What they really should approach is, how is the pain and the disability that goes along with the weakness and the numbness affecting quality of life? And I could go over 3 different studies and guides and tools we use for quality of life, but I use a little bit simpler tool when I'm not looking at my patients for research purposes, okay? And I call it the SLAM, okay? How is this disease slamming the patient? Number 1, how is it affecting their sleep? How is it affecting their activity level? Are they walking with a limp? Are they not able to do their job? This first M is for mood. Are they getting depressed, which is important? Do they have high anxiety? Also very important. And lastly, what meds are they putting into their body? What are they putting in over the counter? What are they taking in terms of opioids? How much are they drinking an extra cocktail or 2 at night? All these things are important in having the patient understand that 6 to 8 weeks after this started, how is your quality of life being impacted? And how do we want to watch that improve? And at what point might we consider surgery? But I really try to pull the discussion away from this fear of permanent nerve injury unless we move quickly to surgery, because there's no evidence around in that first 3 to 6 months, unless you have an extraordinary situation of foot drop, which we'll talk about in a bit, that surgery does a better job versus conservative management in terms of how well a nerve does down the road. Okay? Here's when I consider a pinched nerve from a herniated disc basically a surgical emergency. Complete foot drop or complete weakness in a myotome with a verified disc herniation. We probably see this situation once every 2 to 3 years. It often happens in an obese diabetic patient. And it probably is that the nerve itself is susceptible because of disease in the nerve, kind of microphysiologic disease in the nerve, and a disc herniation really has just caused that nerve to suffer an irreparable damage unless we move quickly. So it's not necessarily the biggest disc herniation you've seen, it's that the exam is showing something that's profound. They cannot move that group of muscles associated with that pinched nerve. And then I would say what we see about every 2 to 3 years is a true example of cauda equina syndrome. So again, as I said before, I want the story, the saddle anesthesia, the difficulty walking, can't feel themselves when they're wiping after moving their bowels or urinating. I want that all together. And I want to move on the MRI quickly. But again, that's a very rare circumstance that we see that. And that's why I brought up earlier about this idea of incontinence and what that really means. Okay? So we're going to move past herniated disc disease. Now we're going to talk about lumbar stenosis. And I love this diagram because I show it to my patients all the time. And it's kind of overly simple, but I think it really points out something important about standing up and actually bending forward. What we call neurogenic pseudoclaudication, which is when I stand, I get symptoms that come out of my back into my legs. And when I bend forward, it seems to get rid of those symptoms. And again, there's many reasons for lumbar stenosis, but the classic one is this buildup that you can see in black here of ligament, which we call the ligamentum flavum, which is just a yellow ligament in the spine. And when we bend forward, that ligament gets tension and pulled off the thecal sac. So again, this is tailbone, L5-S1, L4-5, L3-4. So a variety of things that can cause stenosis, bone spurring, bulging disc degeneration. But keeping in mind the most common thing that clinically brings people to the surgeon is actually thickened ligamentum flavum. So looking for that in the MRI report. Okay, so neurogenic pseudoclaudication caused by multifactorial stenosis. And again, we call it traditionally pseudoclaudication to basically separate it out from vascular claudication. But you can call it neurogenic claudication too, okay? First point here is really important. And I think this is what makes it sometimes clinically a more difficult challenge for anybody, even me. The profile may include back pain, hip pain, sciatica, vague fatigability, numbness, burning, stiffness, achiness, imbalance, and a wide base gait. So surprisingly, there can be very little back pain. There can be very little leg pain, but there are leg symptoms. And the second point, the standard history and physical might be quite unremarkable. It can be the patient says, no, I'm doing okay at home. I can get around. I was in the garden for 2 or 3 hours. It's not really a big deal to me, okay? But the third point is really critical. Prolonged standing, and notice I'm not saying prolonged walking. Prolonged standing should cause an increase in symptoms, and flexing forward or sitting flex forward should decrease symptoms. We call it the grocery cart sign, where the person is in Costco or Fred Meyer or QFC, you name it, Safeway, and the grocery cart allows them to move up and down those hard floors that they could never do with just standing and walking. And that's because that little flexing forward, 5 degrees, 8 degrees, is enough to decompress the nerves in the thecal sac to minimize symptoms. Interestingly, physical therapy does not usually provide benefit and may worsen symptoms. Now, I don't want to tell any of you not to send people to physical therapy. I would merely say, if there is lumbar stenosis in the diagnosis, I think you have to say to the patient, this may help you, and they're going to work on gait training, and they're going to work on balance, and they're going to try to get you with pelvic tilt and standing more upright. But if you get worse after therapy, that might be pointing that this really is lumbar stenosis and not anything else. This disease is best seen on MRI or CT myelogram. I think everybody understands that. So again, looking back at this picture one more time, I bend forward, I decompress my nerves. I stand up, especially when I tell patients to stand against a wall, and a set of symptoms come out of the back, and it can be back pain, butt pain, into the legs. If you are standing against a wall and not walking, it should not be causing typical hip pain or knee pain associated with arthropathy of the knee or the hip. Walking can be very confusing, but standing is really something I use to diagnose lumbar stenosis. Okay, some classic examples here. Okay. Here's an L3-4 disc in a patient. Again, the back side, right side, left side belly. It's an axial view. Here's our thecal sac. The bright white is CSF. Here's individual nerve roots, and this is a little layer of epidural fat. Here's the facet joint on the right and the left. Here's the spinous process and the muscles. Lumbar stenosis. Why has this occurred? Thickened ligamentum flavum. Here it is. And a bulging disc together. If I were to get an MRI on this patient flexed forward, I'd see a picture that looks more similar to that. That's how much it can decompress just by flexing forward. Again, another example. Disc bulge, thickened ligamentum flavum compared to normal. So 2 things happening here. Quite severe ligamentum flavum thickening Okay, thecal sac is compressed down to this small area right here. We'll talk about just how compressed this can be with minimal symptoms. Also, here's the sagittal view. We're going to talk about spondylolisthesis in just a moment, but here compromised also by some natural slippage in the spine called spondylolisthesis, okay, which can contribute to that. So let's talk about this fancy word, spondylolisthesis. A lot of patients will see this in their report. Simply translate, vertebral slippage. Well, that doesn't sound good. I'm slipping. Yes, you're slipping, but you're slipping in like an iceberg moves, slowly. Slowly. This has occurred over many, many years. It might have started at a very young age, but it's slow, okay? The symptoms come on slowly, but it can contribute to stenosis. Just to help you with the nomenclature of spondylolisthesis and the radiographs. Here's a flexion extension x-ray of the lumbar spine. I hope this is well visualized. Bending forward tends to cause an increase in spondylolisthesis. But doesn't bending forward also help stenosis? Yes. So we try to kind of understand these things. Maybe bending forward, this is actually helpful. Even though the spine is slipping, it's making more room and bending back. But this is actually relevant for us to think about from a surgical perspective what to do about this. But I want to reinforce when you're talking to your patients about this, and they look up spondylolisthesis and they get very worried that their spine's going to fall off, say it's been very, very slow and you have muscles surrounding the spine to help protect the nerves. So spondylolisthesis is not an emergency. Here's another example, flexion and extension. You can see it. Slipping forward. This slip forward is only about 3 or 4 millimeters, but it reduces back to normal when extending back. Can spondylolisthesis in and of itself be a cause of back pain? Yes, but it is not always a cause of back pain. Going back to that picture again with the spondylolisthesis and the stenosis. So I want to just get some quick terms and we're going to move on from spondylolisthesis pretty quickly. So the classic older patient you would see in your office basically has slow failure of the joints in the low part of the back, and you get this slow incompetency of an L4-5 or an L3-4 facet joint, and the whole spine slips. Okay. It's not clear to us whether that slip causes an increase in ligamentum flavum thickening because it hasn't been studied well enough. But you can imagine as the spine starts to basically get incompetent, ligaments grow, which causes lumbar stenosis. And again, you don't need spondylolisthesis to have lumbar stenosis. Okay? I also really briefly want to talk about another form of spondylolisthesis and kind of try to give a little bit of a clinical pearl with this. So what I just talked about was degenerative spondylolisthesis. Happens in many people, but there's also something called isthmic spondylolisthesis. Or here's a mouthful, spondylolotic spondylolisthesis. So people can develop either it's there at birth or very young at age, basically a small fracture in a part of the spine that starts to cause a slip. It might be actually 4 to 6 of the population. People with this problem might have had an x-ray of a kid and been told, yeah, you've got a little broken bone in your back and there's nothing to do about it right now. But it is another form of a fracture in the back that occurred either in utero or early in life. It does that because this part of the bone here called the pars interarticularis either broke or never formed normally. So you can imagine the spine over time is able to slip forward. I put this up at the top as a clinical pearl. High school athlete with fall during game, now with protracted back pain. A lot of kids get this problem, especially soccer and basketball players. And we check them out and they get x-rays and the x-rays look okay and there's no slip, and you certainly can't see this on an x-ray usually in a young person. It can be just a hairline fracture. Okay? They go to therapy, they're still not getting better. What's going on? Well, what we would tend to do in a case like that is get a CT scan. We wouldn't get an MRI scan. And a CT scan is the only study that will really show you this fracture, and you can make the diagnosis. Here's a hairline fracture right here. Here's a little bit more obvious one right here. And when we have that, we reassure the parents, we put them in very specific therapy. They can't play sports probably for a semester to try to get that area to heal, and most of the time it does heal. but it can be the type of situation where we have to tell the athlete, the student athlete, and their parents, you know, this could be a recurring problem. We are not worried about a terrible problem where you're going to have a big neurologic injury, but you might find until this really heals, sports are out, and certain sports might be difficult with this over time. Okay? There is surgery to correct it, but obviously you're trying to avoid that in a young athlete if you can. So a little bit more about lumbar stenosis, and then we're going to move on. It's position dependent. It may have zero back pain. You might have pain getting up from out of the car from sitting to standing, but symptoms can be reduced with flexion. Really, there are people, I'm going to show you a case with severe lumbar stenosis who can be very independent, walking, taking care of themselves, but they walk forward like this. They bend forward, okay? It's the classic person who decided to sleep in a reclining chair or adjustable bed because their spine stays flexed forward. That's how their morning stiffness has gotten so bad they find that they fall asleep in the lazy boy chair, it doesn't hurt so much. That's because they've been flexed forward all night. And I always want to make sure we rule in or out associated knee or hip arthropathy. Again, if you stand against a wall and you get symptoms of back pain, butt, and symptoms that radiate into the legs, that should not be hip or knee arthropathy. Those come out with walking. I'm showing you this picture real quick, and I think this is good. I hope this actually comes through. This is an MRI scan. We're going to go through the slices, the axial. This is a person who lives actually on the peninsula. I want you to notice how severe this stenosis gets. Great. So that's pretty bad stenosis. There's a blow up of it. How much is that? That's 2.5 millimeters of room left. So I bring this out as a clinical representation of this lady came to see me, 84 years old, living by herself in swim. I said, you know, that my family has me here because they think I'm having problems with my back. I'm just fine. I volunteer at the church. I live on my own, etc. So I watched her walk in the hall, and she was trying to kind of show off, and I said, well, your legs look like they're getting kind of a little wonky as you walk. She goes, no, not really. It's not. It's just, you know, I'm fine. I said, okay, I'll make you a deal, because I was impressed. This is about as bad as stenosis I've seen in a patient look as good at that age. I said, I'm going to have you just stand here against the wall, and I just want you to stand for 2 minutes. Just stand with your butt and your shoulders touching. And if you can do that, then I'm going to say you're a miracle patient. At about 30 seconds, she said, you know, I can't do this. I go, why? Because you just were walking. She goes, one thing I really can't do is stand. My legs really, I feel like I'm going to lose control if I stand. If I start walking, I feel much better. That's a classic kind of sign that the stenosis is very, very real. Okay? Real quickly about treatment, I said physical therapy is not usually effective. Sometimes if you tell the patient, why don't you kind of think about this standing versus bending forward, see if you can kind of figure out that this is stenosis. And by the way, people will spend 3 hours out in the garden sitting on a gardening stool saying they're fine, and then the next day feel terrible. That's also classic too. So there can be this real confusing, how can it be my back? How can I was moving just fine, but they're always moving in a flex forward position. I, as a surgeon, like epidural steroid injections because they just help with the diagnosis. They help the patient understand it. It also helps us think about other problems that we might be missing. And lumbar stenosis can certainly exist with hip or knee arthropathy together. In well-selected patients, the satisfaction rate of surgery is very high. And believe it or not, the risk is quite low. As long as we say to the patient, the reason for the surgery is your ability to stand and walk with endurance. Okay? It may help their back pain, it may not. It does help people walk and stand better. And again, as I mentioned to you all before, the approach to surgery, slam. How are you sleeping? Are you sleeping in a reclining chair? That's not great. That's not great for the body, but I understand why people do it. What's your activity level? Is this getting you down and depressed? And what are you taking to help with the pain? Very quickly, because patients may come to you and say, Dr. A wants to do this, Dr. B wants to do a fusion, and I don't want that bigger operation. comes up all the time. There are studies that point to lumbar stenosis, especially if you have spondylolisthesis, that fusion's superior, and others that say they're equivocal. And these literally came out a month apart from each other in the New England Journal. Okay, this study in Sweden was a much bigger group than it was in the US, but just to show you, there's data all over the place. So it is the surgeon's job to say, what is the simplest, safest operation that gives us the greatest endurance? And sometimes a fusion operation, even a person in their 80s, even in their 90s, it has acceptable risk and gives greater endurance than laminectomy alone. Real quickly, if we talk about all low back issues, surgery versus conservative care. I just put this up to say it's very patient dependent, but in general terms, if a person has progressive neurologic and neurogenic symptoms, I think a surgery discussion should be had. If this is primarily mechanical low back pain without any discernible neurogenic issues, I think conservative care, therapy, non-operative, pain interventions can be much more acceptable. And without going into reams of data, there's good data to suggest that, okay? We're gonna move pretty quickly now about cervical spine disease. It's a little different. There is a correlate here. Herniated disc disease in the neck. Again, sagittal view, axial view of the MRI scan. Herniated disc. Okay, pinching the nerve here at the C5-6 level. Acute intense periscapular pain with varying degrees of pain in the arm, form, and hand. Patients want to tilt their neck away from the pain, so they're coming in to see you, and they have left pain down their arm, and they're tipped to the right. Always want to rule out shoulder pathology. There's a nice way to do that. If you have shoulder pathology, getting your hand and arm up over your head tends to hurt a lot. Having just basic rotation movements, impingement tends to make it worse. Anything up here, keeping it down at your side tends to feel better, which is the converse of herniated disc radiculopathy, pinched nerve pain. Hanging your arm down when you have a pinched nerve from a disc makes it worse. Holding it, supporting it makes it feel better. Holding it above your head can even make it feel better, right? So always want to make sure, is this shoulder, is it pinched nerve, or is it both? Pain awakens patients from sleep, classic. And again, motor exam becomes key to the diagnosis. And I would say in many ways, more important than with the low back. They're both hugely important, but more important, okay? A good spine practitioner knowing how to say what's C4, C5, C6, C7, C8, or T1. Talk about the EMG. Again, not useful before 4 weeks, but it can be helpful if a person's got compressive neuropathies, carpal tunnel, or ulnar nerve. You want to know if that's kind of added to the set of symptoms here. If you've got numbness in your hand from a cervical problem, it tends to be more consistent and continuous. If you have it from a compressive neuropathy of the elbow wrist, it tends to come on at night. Majority will have pain diminish at 2 weeks. Again, this is sounding a lot like the low back, isn't it, when you look at this slide? MRI is what we use. I would say a chiropractor in particular is probably good after an MRI if you suspect it, because you would just like to see the relationship of the disc to the spinal cord, and most chiropractors would like to see that too. 70% achieve clinical stability at 6 weeks. So again, 2/3 of patients, you just got to assure them in that first 6 weeks, you got a better than 2/3 chance of really being okay if we just can kind of get through this very hard time of severe pain. And our surgical timing, we don't really want to treat anything earlier than 6 to 8 weeks. Approach to surgery the same for the quality of life issues. So we're going to move on now. We talked about radiculopathy picture. What about pinched spinal cord? More serious, more worrisome. The stakes are higher. The need for surgery is very different. Here we have an example of bulging disc, and again, thickened ligamentum flavum. That ligamentum flavum can get you in the neck as well. Here's the spinal cord. Remember, in the lumbar spine, we have a thecal sac. We don't have a spinal cord. Spinal cord ends about T10. And we have this bright white, which is called high signal, right? A sign that the spinal cord's native vascular ecosystem is having a problem when you see that high signal there. Either not getting quite enough blood or the venous drainage isn't quite good enough. Normal axial MRI on the left. And then this is really the cervical stenosis, a bulging disc from the front and thickened ligament from the back. This shows some thickened ligament from the back, and then really plenty of room up front here, that spinal fluid, but a little bit of a bulging disc here, right? Worth an evaluation as long as symptoms suggest there's a problem with the spinal cord. What are those clinical problems? Believe it or not, you can have spinal cord compression with very little neck pain. Arm and hand numbness out of proportion to how the legs. What you really see in the legs is difficulty with balance. The classic cervical myelopathy is, I'm having trouble with earrings, zippers, I play an instrument, the keyboard, these fine motor things. Yeah, my hands are numb, but they're just behaving funny. Again, compressive neuropathies come on at night when sleeping, when the arms are tucked up. Cervical myelopathy, the numbness is there always. You may see increased deep tendon reflexes. You might see increased symptoms in neck extension. When you extend your neck, you also decrease the space for the spinal cord and exiting nerves, just like you do in the low back. If you believe this is the diagnosis, with or without an MRI scan, I do not recommend physiotherapy or any other therapy. I recommend an evaluation, right? Numbness in the hands continue, fine motor problems using the hands, the instrument, the keyboard, and my walking's off. That's a surgical consult or a neurologic consult. Obviously, in that differential diagnosis is multiple sclerosis, Parkinson's disease, ALS, which is really our job in the neuroscience world to figure out. But I have had people with cervical myelopathy who got put on Parkinson's disease medicines for 2 years. So on Parkinson's medicines for 2 years, thinking it was PD when it was really cervical stenosis, and the converse problem, okay? The converse problem. Thinking that it was cervical stenosis because sort of some vague changes in the MRI of the neck, but really it was Parkinson's disease. Primary goal of surgery, whatever the surgery is, back, front, is to stop disease progression. We're very good at that. We also want to reverse symptoms. We get that about 2/3 of the time. And why is that not higher? Why aren't people restored more than 65% of the time? Because cervical myelopathy can be subtle. It can be very, very subtle and attributed to other things, right? So if we get this referral, we kind of bump that person to the front of the line. And we might not be doing surgery the next day, but we will say to the patient, if this is really spinal cord compression, not a pinched nerve, we have to contemplate surgery pretty quick. Anterior versus posterior surgery totally depends on the pathology, and the risk profile is higher than lumbar surgery because of the spinal cord itself. Thoracic disc herniation with myelopathy. Rare. It's much more rare to have this problem in the neck and low back. Why? Because the thoracic spine doesn't move very much. But again, something we want to see quickly. There is a lot at stake here. Obviously, for a thoracic problem, you're not going to see symptoms into the arms. Okay? Smaller pathology can cause greater symptoms. Again, the differential diagnosis is important. Is this Parkinson's or ALS or MS or something else? Imbalance is the primary symptom, not numbness in the legs. Imbalance. And I won't bore you with the physiology of that. Increased deep tendon reflexes, Babinski's clonus, right? Surgery at thoracic spine carries even more risk than cervical. Okay? In part because of how tenuous the blood flow is in the thoracic spine. Again, I won't go into much detail on that, but any busy, competent spine surgeon will tell you that's the one where we really have to have an important talk with the patient. The risks are quite high if we leave it alone, but there is really some substantial risk in taking care of this problem with your thoracic disc. We're going to race through this quickly because this is really a separate talk. You're going to get patients with scoliosis, and then they're going to read about scoliosis, and they're going to tell you what their problem is. Two basically ways to think about this. Adult idiopathic scoliosis. This is the one that started out in teenage years, where curves were first noticed, and again, a very, very slow process. but it should be followed throughout a lifetime. It doesn't have to be followed by a surgeon, it can be by a spine specialist, but again, it tends to affect the thoracic and the lumbar spine. And it's not that 40 degrees is a magic number, but at about 40 degrees of a curve, we start to contemplate surgical treatment and what that means. The other is adult degenerative, which really begins in adulthood. You can have a completely normal spine and have adult degenerative scoliosis occur, and that usually affects the lumbar spine. Again, should be evaluated. And again, 40 degrees is the number we use. Now, I'm showing you this to show you what really substantive curves look like. And this is an idiopathic case. This is a person who had scoliosis in their youth. And basically, you can see the degree of the curves, which are quite substantive, right? And the treatment for that. Again, could do a whole separate talk talking about scoliosis, why we do or don't treat it, conservative things we do. The important thing is when you have a patient who has scoliosis and we think there's pain associated with it, having evaluation x-rays at least to get them on the map to say, we're going to watch this. We'll talk about how likely it is that feeders, but you're not going to progress quickly. That's really what the key is. A couple more slides here. I know you guys probably have minimally invasive spine surgery. What is it? We all use it to varying degrees. The idea is using smaller incisions, special scopes, special retractors to get to the places we want to be in kind of a slick way. Slick meaning, in real terms, less blood loss, less OR time, more patient comfort. Those are all good things. Sometimes there can be visualization problems though, with minimally invasive spine surgery. So as a surgeon, I have to say, in this person and their body habitus, are they best served by me using these tools, or is a more open approach, or vice versa? And that's because superior outcomes with minimally invasive surgery have not been established. So really, minimally invasive surgery is a group of technologic tools that we have to try to reduce trauma associated with surgery. It is not an end-all be-all in itself. And it's evolving and getting better and better. But to the degree which we know, does a person a year after the same operation done with minimally invasive surgery versus not have a better consistent outcome? That's not true yet. Might be true at some point, but it's not true yet. Real quickly, we're going to talk about goals of surgery. And again, these are mine. This is not every surgeon. Of course, I want low risk and high reward. I have to actually make sure that my expectations are the same or close to the same as a patient. Let's take lumbar stenosis. Person says, my back is killing me, I have symptoms in my legs, I want this surgery. Okay, what are your goals? Well, I want to go back and I want to work my land. I've got 4 acres outside of Swim. I got my tractor, my plow, I build fences, and this person's 75 years old. And I say my goals are a little bit different. My goals are so you can stand and walk with durability. If you continue doing what you're doing, the durability of my surgery will be non-existent. So we really try to get aligned with their expectations. And the expectations, they're not my expectations. It's what I know surgery can achieve with durability. We don't have the luxury of hip or knee replacements where you could put in a mechanical device and therefore the spine for 20 years works really nice. We don't have that technology. So you really have to get into your patient's head as a surgeon. What is your expectation and how after the surgery you get better and stay the heck away from me? Obviously their health status preoperatively. What's our blood loss going to look like? I said durability of procedure. I really want patients to understand that. They're going to be in charge of how durable this procedure is, not just the surgery itself. I think strengthening, physical therapy, chiropractic, all these are good things, but they will never save a person from repetitive bending, lifting, and twisting with heavy objects. It will not. The spine's just not built that way. I also want to help a patient to strategize healthy behaviors, not to slow down. So I don't tell the gardener, you can't garden anymore. I say, let's break it into smaller segments to make it easier on the spine. I've made the mistake of using the word slow down. Patients don't like that too much, as you all know, especially people from the peninsula. So I put this is my favorite, for obvious reasons, this is my favorite New Yorker cartoon. It says, listen up, my fine people, singing a song about a brave neurosurgeon who done something wrong. We want to do the right stuff. We want the right operation at the right time for the right patient. But as a surgeon, I've really got to partner and get inside my patient's kind of head and mind and what they're trying to achieve. That's how I really give them the best care and the best operation. Last slide, and then I'm going to open it up for questions. We're all going to see this, degenerative spine disease. I think in the next year, year and a half, you're going to see more of it than you've ever seen before as patients come back to primary care providers. Okay? I love all my fancy tools, especially MRI scans that I use, but the history and physical still is the single most important tool for accurate diagnosis. As I stated a couple different ways, equivalent radiology among patients will have a very different presentation and symptomatology. I've talked about provider engagement, and I think being smart about how they're going to do things before surgery, at surgery, beyond surgery is important. Surgery actually, if you make the diagnosis correctly, the vast majority of it carries quite low risk. Quite low risk. And I would rather have a discussion with a patient about surgery early, even if that's, I think, your MRI scans and overread. I don't think that surgery is ever going to play a role here. What I don't like to have patients come in and say, and I hope you all appreciate this, is, well, surgery is the last resort. Well, I've had surgery on my low back. I don't think anybody wants to have surgery. It's how relevant surgery is at a given time, right? Because I think sometimes people say, well, I'm just going to kind of live my life, and when I just can't take it anymore, then surgery is going to kind of get me out of the woods. That's not really a good way to look at things. So I'd rather have the discussion early and really say what set of criteria would make us want to consider surgery, what kind of follow-up scans we need to make that decision, etc. Okay, I think I've only left 5 minutes, and I apologize for that. But that's my story, and I'm sticking to it. Okay.
Peter, thank you for the great summary, and thanks for the great attendance. Before people leave, I want to, and just get some Q&A, I would just want to remind them about our topic 2 weeks from today. Jonathan Freezer, one of our pediatricians, is going to talk to us about children and media, social media, iPhones, and impacts on their health, if you want to put that in your calendar. So any questions for Dr. Nora?
I do, if no one else does.
Dr. Scott Kennedy has a question.
Hi, thank you very much, and I apologize for coming in late. A couple of us were at the surgical exec next door for half an hour. One question I have is, after a successful herniated disc or spinal stenosis surgery, what type of exercise do you recommend for having that duration that you want to see? Everyone's being recommended to exercise.
Yeah, so I want to be blunt and not rude when I say this, but I'll say to patients, I want you to be active. The more you can keep your head over your ass, the better. Meaning, I don't, if you try to tell a gardener from school, I don't want you to garden anymore, they're going to laugh at you, right? If you tell, so I think all the different, you can get online, you can go to the physical therapist, a lot of things about good core stretching and strengthening, and those are all phenomenally good things to do. But I think it's really getting people's head around the idea of these repetitive activities that we do. And we simply say, you know, if I feel pretty good, I'm going to keep going, and 1 hour leads to 2 hours. Oh, and now my back is starting to bother me. It's time to quit. I try to totally unwind that strategy. And they say, well, what does that mean? I say, that means if you're in the garden for an hour, I want you to take a break. I mean, I try to keep it so simple and blunt. And any group of activities where there is torsional forces of bending, lifting, and twisting repetitively, that's what got us really to surgery in the first place, and it will get us back to surgery unless they develop a new strategy of things. And again, a lot of this is just educating on the anatomy of the spine, how we got to where we were, right? So I can't provide a playbook. I merely say to them, think about all the things you like to do when your head comes off axis from your rear end, right? Think about that in terms of, and do not let your guidepost be, I'll stop doing what I'm doing when it starts to hurt. You've got to get more strategic there.
Real good, thanks.
Yep.
Peter, you might have said this, but in the spectrum of lumbar spinal stenosis and pseudoclaudication, do you want to give us a brushstroke as to how often you sort of see pseudoclaudication in the absence of notable low back pain?
I will simply say, Mark, a lot. It's that MRI I showed of this patient I just saw from, it was stunning to me. Now, as she was walking down the hall, she started walking like a duck, meaning she was getting such a wide base gait to keep her balance. I go, do you have any back pain? And you saw that was 2.1 millimeters of space. No, back pain's not my issue. It wasn't until I made her stand against the wall where she said, I can't do this. I'm gonna fall because I'm forcing her to stand straight. Now, people also, when they're seeing the surgeon, don't always want to tell the surgeon what they might tell you, right? They might think we got the scalpel blade sharpened and we're ready to roll. But I will tell you, the heterogeneity of symptoms in the back and the legs from spinal stenosis is stunning. And probably because spinal stenosis and claudication is probably a microvascular phenomenon, right? I mean, how is that lady's legs even functioning at all? Well, probably it's about micro blood flow to the nerve roots more than actually the nerves being smashed and compressed.
That's good.
We have
Peter, Bill,
a hand up.
Any other questions from our, it looks like we have 14 online participants here. Please unmute and ask Dr. Nora a question if you have.
We have a
one here from
question.
Bill Kittner.
Oh, I'm sorry. Go ahead.
Hi, from Bill Kittner, Peter.
Yeah, Bill, how are you?
Pretty good. Hey, Peter, do you have any comments about the patient presumably with, say, for instance, spinal stenosis or a herniated disc that hasn't resolved spontaneously, that gets good relief from an epidural steroid injection and protracted relief, maybe 6 months, a year, and then recurs and wants another injection? And what, again, with good response, how long do you keep epidural steroid injections going on? Do you have a limit in your mind?
I mean, well, again, I would say it's conventional wisdom that 3 in a year is kind of what insurance wants to use. If a person gets a protracted relief from an injection, I am in favor. You start 6 months to a year, absolutely. Now, I think the discussion, again, the surgical discussion is relevant to say how you walking, how you moving, because, you know, I talk about this walking, flex forward and bend. That's not good for the hips, the knees, the thoracic spine, or the cervical spine. So a person will say, I'm doing well, but I've got all this neck pain, right? Well, they're bending forward and then they're extending their neck like this. So I think I look at epidurals with kind of some caution to say, what did this really allow you to do? Are you out really walking the dog for 2 miles? And if they really are getting durable relief, almost regardless of what the MRI shows, I let them roll with that. Absolutely. Again, I'm not worried really about an acute issue because we didn't get to surgery fast enough.
And do you have any concerns about steroid accumulation or damage over a couple, 3 years with repeated injections, that kind of thing?
I know there are case reports of hip necrosis, and again, I know that exists. I just will tell you in 25 years, I haven't seen it in my practice with a lot of patients getting epidurals, but I know that people who do injections do, basically that's a disclaimer of getting an injection. But I like it for the patient, for the diagnosis also. So I'm not having a patient get 6 injections, Bill, in a year. I say, I think the sweet spot is probably 2 in a year at the most, and 3 maybe, but I think it's a good diagnostic tool for me too. So I don't worry about that.
Great. Thanks, Peter.
You bet, Bill.
We have a hand raised from Dirk.
Hey, Peter, this is Dirk Gouch. Can you hear me?
Dirk. Yes, I can, but
Hey. Great. Hey, I was wondering about that teenage athlete with a spondylolysis and the conservative treatment, or
Yeah.
do you hold, I mean, usually they're that elite athlete that wants to keep participating, and to get back, it takes them 6 months or a year.
Yep.
What are your thoughts there? Thanks.
No, I think, again, I didn't put high school elite athlete, and you raise a great point. And we kind of went through this literature about 3 years ago about, a PARS repair versus an instrumented fusion. I think it can be a very hard discussion. And I think getting a patient with a new fracture versus someone who was born with a spondylolysis is very different, right? But we're up front saying, we think for the next 9 to 12 months, it should be a rehab process for this athlete. If you've got a kid who's a teenager who's been playing soccer his whole life and has dreams of playing Division I soccer, this can be a real problem. But I think the number is really about 9 to 12 months. And then parents usually come in, Dirk, having read all the literature, and say, well, what about a PARS repair? The numbers around PARS repair aren't great. And you're talking about a fusion across a PARS, so it can be kind of tough, right? But the number we say is really, we're going to see you again 6 months into therapy, but I think you have to be prepared to 9 months for a year to really rehab this, if they're an elite athlete.
Yeah, I see it like an ACL tear. I mean, they're going to lose a year, and parents seem to be more of a problem with it.
Yes, I agree.
Thank you.
You bet.
Great talk. Thank you.
Well, thanks again, Peter, and thanks, Sarah, for helping host this. And Peter, please keep us penciled in on your list for a follow-up talk in the months ahead. And best to both of you. And thanks for the attendees today.
Thank you all very
Bye-bye.
much. I appreciate it.
Thank you, guys.